Hi, everyone. This is Eileen Namey, and I want to thank you for sharing your lunch hour with us today to get an update on the PATH project and provide some input as we move forward on the project. So I'm the principal investigator on this project. I'm joined by Divya Patel, so co-principal investigator, and our research coordinator, Dagoberto Cortez. Most of the people on the call are familiar with the project and have been involved in some capacity, so thank you for your time up till now. And we also want to give a big thanks to St. David's Foundation for their financial support and leadership broadly and women's health in Central Texas. We're going to jump in. I know some folks will probably be joining us as we go, but we just have an hour, so we'll just go ahead and move forward, and people can join when they get in. So just going to say quickly what we're going to talk about this hour. We'll give a brief background on the Texas Collaborative for Healthy Mothers and Babies and the PATH project, just to reorient everyone. Give an update on where we are in the project from a process and logistical standpoint, and then just share some preliminary data that we've gathered so far to give you a feel for what we've pulled together so far and where this project is heading as we finish out the year. We're also going to provide some time for you all to give us some input, and we want you to use the chat feature at the top. You'll see a button that says chat. That will send a message to us. And this, you can use this at any point during the slideshow, and we're interested in any reactions you have at all to things that we're sharing. Does this information seem useful? When we get to the quotes, are the quotes, do they reflect what you know to be true, what you've experienced in your work, and are inferences on track? What questions maybe does the information we're sharing raise? What are you hoping that we might, what kind of questions would you like us to be answering as we finish out the project? You can do that any time, and we'll also have pauses at certain times where we'll give you time to just write those chats. If there are questions that you want to ask that we can answer while this is going on, we will, but if not, we'll respond to you after the fact. And this will be available as a recording if you want to share with others, with colleagues. So the Texas Collaborative for Healthy Mothers and Babies, this is the Texas's Perinatal Quality Improvement Collaborative. There's over 150 health professionals across the state that are working to improve care for all Texas mothers and babies. So there's a lot of goals of TCHMB. At the heart of it, the collaborative seeks to improve the health outcomes and reduce disparities for mothers and babies. There's also an interest in improving women's health throughout the life cycle, and I think this project is particularly relevant to that last goal. So just a little bit about the PATH project, refresh everyone. This is very much an applied research project. At the heart of the project is gathering the stories and perspectives of the people here in Central Texas. That includes pregnant and postpartum women who are relying on publicly funded programs to cover their healthcare costs. And it's also people like yourselves who work with and provide care to this population. We want to understand how state-level programs that aim to increase access to care are being operationalized here in the community, and then take this information and input from, that we're gathering in many forms, including through this webinar, to develop some recommendations to help improve access to care. I want to acknowledge, as we've been going in, digging in and learning about what's happening here in Central Texas, there is a tremendous amount that's going on right now. So we want to make sure that we're trying to make sure this project helps to inform and complement and support these other efforts. There's a lot of work that many of you are involved in. St. David's is making a lot of investments. There's a lot of community-based organizations and statewide organizations that are expanding their work in this area. We know that the FQHCs here are innovating and improving their programs and their service delivery. We know HHSC is working on improving coordination and communication about their programs. And most recently, the legislature has passed several bills that also impact maternal and postpartum care and aim to improve service delivery. So this program, like I mentioned, we are pulling together quantitative information, but really at the heart of it is these qualitative interviews. And we are looking to interview at least 30 women and over at 3 different time points. So late prenatal and then a couple times of postpartum. And we also are speaking with clinic staff and community stakeholders, like many of the folks on this call. So what I want to give next is just an update on where we are in the project. So we are actively recruiting participants. We've got 2 clinic systems that are helping us with this, and we've reached out to a number of other parties that work with our population that we're interested in speaking with. It's been harder to get into, I'll say, the Hays County and Caldwell County, finding the right partners there. We've had some great reception from folks, but we haven't quite found an in to help recruit. So that's kind of an area of weakness that we're working on. But in Travis, Bastrop, and Williamson County, we have partners that are helping us with recruitment there. So to date, we've got a set of trained interviewers. I'll mention that, and so we've trained our interviewers, and they're well versed in qualitative methods and have been doing a great job with the interviews. We've got 31 women who have agreed to allow us to contact them, and some of them are still in process. And we've got 9 women that have consented, and we've completed 10 interviews to date. All of these, I'll just say a little bit about the participants. They've all been Travis County residents, and we were aware going in that would be the easiest area to reach women in this area. So we're making a concerted effort to expand that to the other counties as well. We do have a mix of both English and Spanish, primary Spanish speakers, and a mix of folks who are covered through women who are covered through the CHIP perinatal and Medicaid for pregnant women. So there are probably about half of the women who are, well, five out of the 9, I can't say half, who are undocumented. And so that was a population that we weren't sure how easy it would be to reach, and so we're glad that we've been able to have some of those women join and speak to us. We've also conducted 5 interviews with clinic staff, and this is just a selection. I think we plan to have probably another 5 to 10 additional interviews with clinic staff. And we have also had some conversations with various women's health advocates and stakeholders that are working in this area. It's just a few of the folks that we've spoken to. So that's where we are kind of in the process of the project. I'm going to share a little bit next about some of the geographic information. This is quantitative information that we've compiled that helps us kind of set the stage and understand a little bit about the population and where they are. So this is information that came from the hospital discharge data, and it's lets us know where are the women whose births were covered by Medicaid, where do they live? And this is at the county level. And for our 5 counties, one thing that stands out to me is that they're the smallest of the 2, the least populous group, are the ones that have the highest percentage of births that were covered by Medicaid. So Bastrop and Caldwell. So, I think we tend to focus in on Travis County and the larger counties, and the need that the women that live in these less populous counties are maybe have greater needs on a per capita basis. And we definitely are wanting to hear more from them and from their experiences. So we also took a look at a little bit finer grains. This is at the zip code level. And what we can see here is just that there's a lot of variation even within the counties. So this is just the top 10, the percent of births covered by Medicaid. And we see it's nearly 80% in some of our zip codes. On the low end, there are zip codes with 1%, 2% that are covered through Medicaid pregnant women. So it just shows that there's a lot of geographic variation, especially in small areas. And the orange zip codes are also actually the most 10 most just numbers, in terms of numbers, the highest number of women covered through had their births covered by Medicaid. So those are zip codes that were both in percent-wise and on a count basis the highest. So we took this information. I'm going to switch quickly over to a map that we've been working on. So this is a draft, and this is a map that we've been putting together so we can have a visual and share this information in a way that may be useful and accessible. So this is layers of data that we've been pulling together. So some of the information I just shared with you can be seen in these pop-ups at the zip code level. So what the map shows visually is we can really see that some of where we're seeing the highest, the darkest color is the highest percentage covered of births that were covered through Medicaid. So this is the home zip code of the moms, that they are really, in the surrounding areas. And, it does make us think about, as we think about where women are getting their care, are some of these women actually, are they getting care outside? They live in these counties, they live in these zip codes, but perhaps they're receiving care outside of this 5-county area. And it's something I think it's useful to think about and talk about, just really understanding how those boundaries, we're focused on this 5 counties, but wanting to know a little bit broader. So one of the things that we also have a map of, or added to this map, are the delivery hospitals. So this is where women who live in these counties or live in these zip codes delivered their babies. And again, there are pop-ups here where we can see the distribution by if it was covered through Medicaid or through private insurance. So there's quite a wide range there as well, as you see here, about 1%. And about half here at Seton Medical Center Hayes. So it's interesting to take a look at that and see how it varies at the hospital level, and also know which hospitals would be good partners as we think about connecting with this population. So that's another layer. And then we've just recently added, this is information that HHSC provided in their most recent report. This is the Healthy Texas Women, the facilities that have served at least one. I'm going to take this off right now. So at least one woman through Healthy Texas Women. And the circles are proportional to the size of the population. And so in some cases, there may be 9 clients that were seen. 9 clients. I think there's some that are, if they're even down to 1, and then on up to some of these larger. Oops, that's at the. Yeah, it's a tremendous number here. So there's definitely some clinics are seeing a lot, and it also gives us a feel for where these clinics are. There are some clinics that are Healthy Texas Women that are on the list for Healthy Texas Women, but didn't see any clients. Those are not on this map. So that's the map. This map will be publicly available. We would love any input on this, information you'd like to see included in here, questions that it raises. Please share that with us. And is this something that would be helpful for people to kind of get a feel for the population that we're seeking to support and serve? So at this point, I'm going to hand it off, I believe, to Alberto, right? Yep. To talk a little bit about what we've learned from some of the qualitative interviews with women.
Hi, everyone. So preliminary data analysis shows that women and clinicians struggle with information on multiple fronts. What the next 3 slides will show are some examples of the various informational challenges that participants faced and experienced. But before we launch into the data, I want to mention that we realize that women receive a tremendous amount of information in the prenatal stage, into delivery, and throughout the postpartum period. And that information is important. Yet there are times when clinicians and staff have to maximize the time that's spent with patients and balance that with all the information that they have to provide them. And so what we're seeing is that sometimes there's just a misalignment between what the clinicians want to present and what women need and want. So in the first example, we have a quote from Gus. So Gus is a fake name. We gave an employee that for Texas Medicaid's enrollment broker, and he's explaining he's reflecting on the women that he's helped. And he says, so we do provide the information about Healthy Texas Women as well. Whenever we enroll them with a doctor, a health plan and stuff, we give them so much information that that small piece is probably going to be something that they don't remember. They do get that information, but again, it's something that towards the end of the pregnancy, they're not going to remember that they get it and 3 months pregnant or 4 months pregnant. And so here, I think what Gus is telling us is that he's recognizing that women are inundated with information at every stage of the pregnancy. His quote keys into a major tension we're seeing emerging in our data analysis, which is clinicians are trying to present information that's really important and trying to find the right time to present that information so that women retain it and remember it when they need it. So in the last example, we saw Gus describe the difficulty in presenting information during the prenatal stage. In this example here, we're going to focus on the time period right after delivery when women are still in the hospital. In this quote, in the first quote, we have Maria discussing her ability to comprehend instructions and information right after giving birth. No?
Any wet diapers he had and at what time, when he fed, and how long did he feed for. That was the first thing that they had me keep track of. The second thing was that they had me keep track of how much I peed. So I had to pee into like a thing that was in the toilet, and I had to how many milliliters that of urine, and then they had at what time. They had me do that. And when she was giving me the instructions, I was barely comprehending anything she was saying. But so that was kind of like the first night. Yeah.
And so here, Maria's quote shows us how difficult it can be to comprehend basic instructions, let alone understand and remember other types of technical information or information about, let's say, public health programs. It shows that right after delivery, new mothers might not be ready to discuss topics that maybe clinicians want to discuss. And in fact, a doula that we spoke with nicely conveys this point when she told us, when the women are in the hospital, you had all this information, you had overload of information. It's great to have this information, but once you get home, you face reality. You have other children and other issues going on. And so again, this is just kind of surmising or just reflecting kind of what we heard Maria say, which is there's a lot of information and oftentimes women just aren't ready to hear that. Participants also expressed concerns about not having the right information at the right time. One example is seen when Maria tells us that
really didn't have any questions till after I left the hospital. Because while you're in the hospital, you're obviously going to be sore, and obviously you're going to be feeling kind of weird and tired and all this stuff. But it's when I got home that I was like, wow. And that's when I really had questions. I was just like, well, is it normal for me to be hurting like this? Swelling up. I had a lot of swelling in my ankles and my legs. I had a lot of pain. I still do. I still sometimes find my back swollen, feels really stiff.
Maria nicely expresses the misalignment between when her healthcare team presents information and what information she feels she needs. She helps us understand that sometimes women don't know what they're going to feel when they get home until they actually start experiencing it. And it's at that point that they want information, but they're at home and they're not receiving it. And so right now we want to pause and.
Sure. Yeah. If anyone has, what we'd like to hear is, do so far the quotes that we've shared match up with your experiences, your understanding of what women are experiencing? Do there is any questions? Do our inferences seem accurate, or would you have interpreted these in a different way? So we'll just take just a moment. If you want to add a chat, you can use the chat button to just share anything with us. And it's just going to come here directly to our group. It won't be shared beyond this. Okay, we're going to go on to the next.
Yep. So another salient theme we see emerging is how much confusion and uncertainty exists about public health programs and about how women are going to cover their healthcare costs. In the quote where I'm about to play you, we have Julia expressing her confusion about the application process and recalling just generally the uncertainty around how her healthcare costs were going to be paid. Julia tells our interviewer that
maybe applying sooner, because like I said, I didn't know about like insurance that I had to have. I didn't actually know that I had to apply for insurance during pregnancy. I actually thought the MAP would cover everything, but apparently it doesn't cover any pregnancy things. So when I found out about the baby insurance was when I was like, oh, you have to do that too. So and I think I did apply a little bit later, like about my 3rd month maybe. So yeah, I would just encourage like apply sooner. The sooner the better.
And so in the next quote, in the next exchange, Julia continues to describe how she was thinking about her coverage when she was pregnant and the stress that uncertainty and that caused.
It took a while to get approved though.
How long is a while?
About 2 months.
Wow.
Yeah.
Okay.
Yeah, and it was kind of hard for me because I would come to the appointments and they would ask me, do you have your insurance yet? And I would be like, no, it's still getting approved. Yeah. And I was kind of scared at first because I was like, what if I didn't get approved and I have to be paying for all of this? It was kind of worrying, but you know, I got approved.
Yeah. What made you feel worried? What were your thoughts? What were your worries?
I guess I was just thinking that maybe if I didn't have insurance, I wasn't gonna have like the opportunity to get my baby checked because I don't know. I just thought that I wasn't able to make the appointments for my baby to make sure that the baby's okay without the insurance. So that's just what I was worried about.
So this exchange between Julia and the interviewer nicely shows that there's quite a bit of stress associated with acquiring coverage. Also, we see Julia worried about what she says that she might not get approved. And so while Julia meets all the eligibility requirements and her approval for CHIP perinatal is a matter of getting the application processed, her perception of what that approval process is really kind of fueling her anxiety. And that period between applying and getting approval, the approval notification is a major source of not only anxiety, but it started affecting kind of how she thought about coverage and what she knew about coverage. So when we interviewed clinicians and staff at clinics, they too often discussed the confusion that patients had with all the programs and the services they covered. One administrative staff member was discussing the amount of information and some of the struggles that patients had to kind of understand all the information that they're being provided. So right before this quote, the staff member says that she simply thinks that, telling women isn't enough. She then says, I think communication falls a lot to this here. Patients get this and they don't even know what this covers and what this is. Here are just the different programs. And so they just give it to them. They'd be like, I don't know what I got. I've seen it numerous times where I'm on the floor and I'd be like, well, what insurance do you have? The patient says, I don't know. They just gave me this and they'll give me the package. And I'm like, oh my God. So I have to look and see what they actually have. And then I explain to them, I'm just like, well, this covers this. This is FPS. If you need medical, anything, this is what you use for that. And so here, the staff member is trying to, is explaining how even after patients are covered or receive information about coverage, there's still quite a bit of uncertainty around what services are covered and what that coverage entails. And while the staff member is talking about the patients here, our data are also showing that there's quite a bit of uncertainty as far as the staff members' understanding of these programs. They often have a difficult time understanding the eligibility criteria for programs like Healthy Texas Women and Texas Family Planning, and even have questions about what services those types of programs cover.
Great, thank you, Dagoberto. So we're going to switch gears a little bit and talk about some of the barriers to access that we are hearing from participants in this study. And we know that there are a range of factors that can affect a woman's use of pregnancy-related care, and this is generally for all women. But underserved women in particular, and even more so women of color, may experience unique barriers to access of care before, during, and after pregnancy. And I think just stepping back a little bit, I think that's the unique aspect of the study, is that we're able to hear this from multiple perspectives. So we're listening to the women themselves who are facing these challenges. We're hearing from clinic staff. We're talking to administrators, people that make decisions, and we're kind of learning about how this is affecting women's access. So we also wanted to thank, just take the chance to thank all the people that have participated in the study up to this point, because they were willing to share their candid experiences in a way that helps us tell this story. So from some of our early interviews, we're hearing, again, both from women and from clinic staff about specific challenges faced when navigating the healthcare system during pregnancy and after pregnancy. So in this kind of short excerpt, we're hearing from a participant and specifically related to the distance that she has to travel to get to her appointments, and then the related transportation issues.
At first, I was taking, I was eating a ride from my grandmother. She was giving me a ride. That was good and dandy, but that was taking out of her day, her time, do all that. And so that was kind of a strain on our relationship, because she was always like, oh, I gotta take you to the doctors, every single time. And at that point, it wasn't that much, because, when you're first finding out you're pregnant, it's like once a month or something like that. But it was really far up north from where I lived, and that was the only OB office that they had in Austin. That was the closest one they had to me. They didn't even have one south at all, central or east or anything. We only had one way up north. And so, I'd asked her to take me because, at the time I moved here, I wasn't really familiar with the bus system and how to do all that and get on the bus and go all the way up north on the bus. And it just seemed so daunting. So she did that for a while, and then that kind of wore out its welcome, and then I started taking the bus up north. And that kind of led to me having a lapse in care for like 2 months. Yeah, unfortunately. Yeah.
So at what point in your pregnancy did you say?
It was like the first trimester going into the second.
Okay.
Yeah, I didn't go for like too much, just because it was just too much to try and get all the way up north on the bus. Yeah.
So thanks for kind of bearing with that long excerpt, but I think there's a lot going on in this conversation that is just worth touching on. So we hear a lot about the long distance and the location of the clinic related to where the woman lives, and there aren't a whole lot of options nearby. We also hear about her having to rely on a family member for her transportation, which seemed to work out okay when there were monthly visits to the OB, but then when later in pregnancy, when the visits got more frequent, that was causing a strain on that relationship. So stress on the woman and her family member. But ultimately what this led to was that lapse in her care. So she says, and she acknowledges that there was about a 2-month period during her pregnancy where she just simply couldn't go. And a lot of it was probably related to the transportation issues and the distance. So I'm going to kind of just go on a little bit with the same interview because it highlights in more detail what the woman is facing. Oops. Sorry. Okay. Sorry about that.
So about how long did it take you to get up there? On the bus?
Like a couple hours.
Wow.
Yeah, because of how many stops they have.
Mm-hmm.
You know, like you get on the bus and it stops, and then it stops, and then it stops, and then it stops, and you have to transfer on another bus, and then they stop, and then by the time you get where you're going, in the bus stop that we went, it stopped us at. It wasn't exactly in front of the hospital. You still had to walk.
Yeah.
So then you get off there, and then you have to walk to the hospital, and it was just like, and then being pregnant, and so it took a long time, a couple hours or more.
Yeah, just one way.
Yeah, it was one way.
Yeah.
So total 4.5, 5 hours.
Okay.
So this was a really telling part of the interview because it's almost as she's walking us through what it takes for her in how she experiences that commute to the clinic, and she goes on the bus and it stops and it stops and it stops and the transfer, then she gets off and she has to walk, and remember she's pregnant, it may be hot outside, there's so many things that are going on here, and she says one way for 4 or 5 hours, and again, compounded with issues with how do you get that time off of work and how, all of the things that are going on. I think this was just an interview that shed some good light on the challenges facing women accessing care. All right. So from this one we wanted to share with you is from the perspective of one of the social workers. And now the social worker's role in the clinic is really to assess barriers that the patients are facing, and not just clinical, but also other things, social, economic. So she's very, very aware of the challenges facing this population. And so she gave a lot of information. I'll just read it. Many things that our patients are facing. A lot of the things that we have on the health risk assessment, barriers to care like transportation. Yeah, a lot of our patients don't have vehicles. So they either need to use the bus system, or since a lot of them are recent immigrants, are kind of scared of the bus system. Or sometimes people who aren't recent immigrants are scared of the bus system or have to take 2 or 3 buses to get here. Sometimes they can't afford bus fare. We have a fair number of patients who live in areas where there is no bus or no bus route. And so that's a real challenge, like people who live in Del Valley. We do have patients who are coming in from surrounding counties or areas of Travis County that are outside of the city limits of Austin. So that's a real challenge. Affording gas is hard. Sometimes people who do drive, I had a patient we've had a number of patients who come from Killeen to get care, so coming really far. So I think that this interview really reinforced some of the issues we heard directly from the women. In addition, we heard about how these barriers to access can be compounded for certain women, particularly recent immigrants. And then she goes on to say that it may be for everybody, not just recent immigrants, but for anyone who really needs to traverse substantial distance to get to the clinic. So another thing that kind of has come out from our early interviews is that we're really hearing about the important role of culture in women's health beliefs and their practices, and even how they seek health care. So I thought that this was kind of an interesting example to share.
I don't know if it's because like where we are from, it's just something that we don't really do. Well, usually what I do, like for example, and I was just telling my doctor last visit I had with her, I was having a lot of friends and family members tell me that eating coconut is bad during the pregnancy, and I never asked my doctor about that, and I've been craving coconut so bad. And I had just, been holding back that urge to eat coconut because I was like, what if it's bad for the baby? So I wasn't eating any until this last visit last week that I told my doctor, I'm like, so is eating coconut bad? She was like, no, it's safe. So I guess it's something that I don't really run to the doctor first thing, unless it's something really serious. Yeah.
So there's a lot of really rich information here, and she kind of, giggles, and she gave the example of eating coconut. And while we may know that that's not necessarily something that would be dangerous, but it's interesting to note that that was something that was really important to her. It's something that she clearly had questions about. She was withholding doing that, but the information that she was getting on this is really from friends and family members as kind of the first line or most trusted source of information. And perhaps, the kind of cultural norm that when things aren't an emergency or they're, not so serious, we would trust, our family members or friends to kind of give us that advice. And it wouldn't be until there's something that's really serious, as the participant says, that we would seek out that information from the doctor or the nurse. So thinking about and acknowledging sort of those trusted sources of information, and then those challenges that might create in accessing information, and also acknowledging that that family and friends are an important source of information for many women. Okay. All right. And so going back to our interview with the doula, who primarily serves African American women, we heard a little bit more about trusted sources of support and information, and particularly for women of color. So I'm going to read what our doula shared with us. I came at this just working with women of color. We need to get into churches and get to the little old ladies. I shouldn't say old ladies, but that's who they are, because if old Mama Williams tells them to do it, they're going to do it. They're not going to listen to anybody in this room. You could have the Surgeon General telling you, if not Mrs. Williams, it's not happening. Women of color, and Black women in particular, they ain't listening to you. You're talking to them and they're looking dead at you, and it's like womp, 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 just like on the Peanuts. And it's just because there's been so much going on and so much historically that has happened. You've got to get it through. They're going to listen to someone who they trust. You're going to have to figure it out who that is and then partner with those people. And so, we wanted to end here and just kind of share those quotes that we found kind of particularly relevant and important, and also just kind of our early interpretation of the interviews. I think sort of the value of this project is we have the opportunity to learn and then try to understand cultural and historical influences and how they are impacting access to healthcare before, during, and after pregnancy. So I think I'm going to turn it back to Eileen.
Just share a little bit about our next steps. So we are still working on participant recruitment. We're going to complete our participant recruitment, and we're going to continue the interviews, including the second and third interviews. These have been primarily prenatal, and the big focus of this project is in that postpartum period. And so I think there's a lot we'll learn going into that. And we had the opportunity to speak to the same women again and refine the questions that we asked. So we're going to be looking at what they said in their first interviews and giving some information to the interviewers to make sure that we're following up with anything that came up in those first interviews. And then we're also conducting additional staff interviews and key stakeholder interviews. we'll be holding a meeting on November 1st, a public meeting. We'll share that information with everyone who's been on this call. And it'll be 4 hours to not only share the findings that we've come up, and then some of our preliminary recommendations, but have an opportunity to refine those recommendations and get input from folks that attend. And then we will have a report that's released in January. We will likely be continuing, interviews through the end of this year, and so some of that information we'll be continuing to analyze throughout the year and even into next year. But we will be producing, we'll have enough information to produce a report by the end of January. We have one more slide? No? Okay. So just to wrap up, so there were some salient themes that we mentioned so far, and this is again very preliminary, but there's a lot of conversation around information needs and the timing of that information. Some information that we're hearing about, various barriers, and these are things that have been talked about, but here we're hoping that putting some stories behind it will help just shed a little bit more light and puts a human face or human voice behind it. And then also understanding that there are a lot of cultural influences on care seeking. I want to mention, we didn't include, there were certainly some really positive things. There were a lot of positive feelings towards the providers, there's clinicians, social support, references to social support. And there was also a lot of evidence of outreach trying to communicate to both the women and to providers and clinicians about the women's health programs. So we heard a number of times where someone had said, oh yeah, we had a presentation about Healthy Texas Women, or so they knew the information was coming in. At the same time, there was a lot of uncertainty on the details, and we think that this is, it's just a factor of having so much information that's coming in at the same time, both for the women and to some extent for the providers, trying to not only think about the health, but think about the broader social needs, connecting women up with other resources in the community. And in the context of all that, the details of enrollment process and what's covered and the timing, it's hard to keep that all in place all at once. And we also heard that there is a perception maybe that some of the state health programs, the Healthy Texas Women, is more narrowly focused than it truly is, that it's focused on contraception, and in reality there's more that it offers, and so it's important to kind of make sure that information, as challenging as it is, but to shift the understanding of those programs, because there is more to it than just contraception. So in summary, I think that we certainly can take steps, and we should take steps to improve the content and timing of communications, given how much information people want and need, and a lot of that information relates to the experience of pregnancy, the experience of recovering from pregnancy and taking care of children. Some of these details, it's hard to hold on to some of these details, and so as much as can be done to minimize the need for information, simplify, and continue down that path of trying to integrate and make sure that these programs are seamless, will go a long way. It's equally important to figuring out how to communicate better about these programs. So we want to just have a few more minutes. Anyone who has comments that they want to make at this time, we would love to hear them. If there are questions that we can answer as well, we can try to answer them now. And again, if we can't answer them now, we will get back with you. So we'll take a moment to just see if anyone would like. Please use the chat box at the top.
So while we're waiting, we don't have any questions so far, but we did have one comment, and we heard that no specific questions, but these qualitative quotes are so rich and insightful. It's critically important to listen to women and elevate their voices. So we hope that this project will do that to whatever extent we can, and we appreciate the comment from you.
So at any time, there's some contact. Let me get to the lot. I think we have one. Sorry, one more slide. Wait. Yeah, I just want to say thanks to our team. We've got a lot of great folks that are working on this project. In addition to Divya and Dagoberto, people mentioned here that make this all possible. And again, of course, a big thanks to St. David's Foundation and folks like you on the call, our project advisors and our clinic partners. Big thanks to everyone. And contact information, I want to go back. If you can reach out to me directly with any questions or comments.
Well, yeah, we had another comment, it says, I find it so interesting that many of the stories shared coincide to the barriers and issues we hear from moms in relation to breastfeeding. For example, I had all the help in the hospital, but none when I got home. Mm-hmm. So, yeah, definitely corroborated by what we're hearing.
And, I'll follow that up by saying, in that quote where I believe it's Maria is talking about how when she got home, she just had so many questions. She does go on to say that someone at the hospital followed up a week later and that it was great that she was able to talk to her, but that she still had more information. She still had more informational need than could be conveyed in that one phone call. But she did say, the clinic staff at the hospital were great and that they followed up with her. And she really appreciated that because she did feel that the time she left the hospital and the time she went in for her next clinic visit at her clinic was almost like it was only 2 weeks, but she felt like it was 2 weeks, almost like a week too long. She really wanted to go in there a couple days after because she wanted to talk to someone about her physical symptoms that she was experiencing. And so, it's just, to me, that just highlights not only some of the great work that the hospital clinicians were doing, but also that for Maria, she really wanted to go in right away. And she saw that, even though she loves the care that she receives, she saw that as a major misalignment between the policies of the clinic and her needs.
Yeah, and we just shared an excerpt of the interview, but it was really interesting to hear that she had some immediate feelings and issues that she was facing. And it was almost a sense of relief when someone called her at home. She had that opportunity to ask, I'm experiencing this, is this normal? And once she was able to hear, yes, that's normal, and we'll check you again when you come in for your 2-week visit. Right. It was like, almost just a relief that things were going to be okay. And I think she expressed that was really important to her, and that had she had to kind of carry that anxiety for 2 weeks, that would have been really stressful. And so I think there are supports in the system that are happening and they're really positive for women, and wherever we can kind of learn from that and seeing what's working and what helps women, that it's really great information. Mm-hmm. So I think another comment again from the same participant is, repetition of the presentation of so much information in addition to the timing is crucial. Multiple passes of presenting information and follow-up makes a huge difference.
Yeah, and I think even Maria in her interview might have even indicated that she might have received this information earlier, but she didn't remember it about her swelling and about. It was only after she was done with having the baby and that she was home that she could actually retain the information. So whoever made that comment, we totally agree. At least that's what the women are telling us, that it's that if you tell them once, that means that they might need to hear it again later on.
Yeah. It also clearly points to that women want to know what to expect, whether what they're experiencing is normal or abnormal, and so just a need and want for information is out there. So I think we don't have any additional questions or comments, and
we'll give you all back 10 minutes.
Really appreciate all the time and input.
Mm-hmm. And we are here. We are very interested in hearing from you at any time. Please send an email. You can also call. And we definitely are interested not only in, if you have comments or you think that we're going on the wrong track anywhere in here, please let us know. We're open to any feedback at all. And also in thinking about, we are here to support and complement the work that so many of you are doing in the community, and we want this program or this project to help in that regard. So if there are specific things that would make it be more valuable to you, we have the opportunity to continue with these interviews and ask more questions. Please let us know what you think would be most useful. And with that, we'll say wish you a good afternoon, and thanks again for joining us.